welcome to the Health and Wellbeing Board. Lots of people here in the room and lots of people on screen. So I will, if you put your hand up if you want to speak, George will help me and I'll be looking on the screen as well. If I could, rather than us all going around and introducing each other again, if we could just say who we are, if we're speaking. That's right. I need to also remember to do that myself. So I'm Councillor Jane Somper, and I'm the Chairman of the Health and Wellbeing Board and Cabinet Member for Adult Social Care, Health and Housing, and I represent the Beacon Ward. So we can now move on full into the meeting. George, could you give us any apologies, please?
Yes, we have apologies from councillors, Councillor Spencer Flower, Jan Britton and Patricia Miller.
Okay, lovely, thank you. And can I ask if any member has any declaration of interest that they wish to make today? No, okay, good, we can move on. Agenda item 3, the minutes. Could I have, I'm assuming people have read minutes, happy with them. If I could have a proposer and a seconder to approve those minutes from a meeting held on the 20th of November. Gosh. Can I have a proposer? Thank you. Thank you. Lovely. Rolling on. Do we have any public participation questions, or I'll roll them into 2 with councillor ones either?
No, there's no public participation. Councillor questions.
There are no urgent items. We're already on agenda item 7. Look at that. Going through at speed. So agenda item 7 is going to be introduced by Sarah Sewell on the Better Care Fund on quarterly reporting. There's a little bit of a case study. I don't think we're going to go through the whole case study, but maybe to pull out. Thank you very much. There we go. Okay. Right. Okay.
So good afternoon, everybody. Good afternoon, everybody. I'm Sarah Sewell. I'm Head of Service for Commissioning for Older People and Home First here at the Council. So the item that I brought today is you're used to seeing me kind of come along with the retrospective approvals, but so here today we've got the Better Care Fund plan, then it's the quarter 3 reporting template and the case study. And due to the reporting timelines that come from NHS England, it's very difficult for us to align to health being boards in advance, which is why we tend to be retrospective. So just by way of a quick summary, so to date you'll recall that we have brought in this current financial year to the Wellbeing Board, who have ratified also our plan for 23 to 25. So we moved to a 2-year planning cycle this year. And we've also previously brought our quarter 2 reporting template, which again the board approved. So we're in the next assurance check for quarter 3, and this time round NHS England asked us to provide a case study of one of our schemes. So just by way of a reminder, we have a BCF policy objective, which echo our local shared priorities. So that's around enabling people to stay well, safe and independent at home for longer and providing the right care in the right place at the right time. The BCF policy framework continues in line with previous years. So we must meet the national conditions, and there's a set of national performance metrics that we report against on a regular basis. And in terms of monetary value, the BCF provides Dorset as a total funding of 146 million in the financial year. So within your report pack today, the quarterly return is in 2 parts. So Appendix A, which is a spreadsheet which has several tabs on there, confirmation of the national conditions being implemented, our reporting of our performance against our BCF metrics, and also some of the challenges and achievements that we want to report against, our actual expenditure and outputs against our forecast, and then in addition, as a reference, a case study which is in Appendix B of your pack. And just wanted to remind you there of the 5 BCF metrics that we track as we go through. So just in terms of our performance, so we're on track to meet BCF metrics in our discharge normal place of residence schools. We are challenged in 3 areas, which I've described in more detail in the reports, but just to kind of highlight those to you. So avoidable admissions, we experienced as a system increased demand during the first 6 months of the financial year, which was about a 6% increase. We responded to that with a new at the front door, which we've tested over the winter period. The initial impact is appearing to be positive, but there's close monitoring of that's needed ongoing as we kind of move forward. And you may recall at the last board, we talked in a bit of detail just in terms of our rates of permanent admissions to residential care. Our performance is showing improvement against our Q2 position in Q3. And again, we continue to monitor that as part of our sort of business as usual adult social care monitoring. And then finally, in the metrics, our measure around reablement. So this is a measure of older people remaining at home 91 days after discharge. And as again, we explained in the last report, availability of therapy is a challenge around our ambitions for reablement. We have done a lot of work in our discharge to assess model offer, which is enabling far more people to be supported home sort of through that offer. And those improvements that we've made through there has broadened our reablement offer. Our use of trusted provision is really helping there. So what we plan to do is include that performance in our Q4 reporting. So we hope to see a difference when we get to that position of the report. So the 2 different elements in the return this time round were around spend and activity rather than demand and capacity, which was in the last set of reports. And our return asked us to report against our actual activity and spend versus our plan. So I'm pleased to report that our performance was on track in all of the areas, and we actually exceeded the forecasts around assisted technology and equipment and also our home care capacity, which again is great sort of improvement to our offer and the enhancements that we've made through our discharge to assess approach. And then finally, just in relation to the case study, we based our case study around our Home First Accelerator programme. That's in Appendix B of the report pack. So we were asked by NHSE to explain several elements of a scheme that was BCF funded. So this is a robust programme that we've pulled together as a local system to redesign the social care out of hospital provision, and that's part of developing our intermediate care strategy. So it sits alongside a wider plan of action around developing our provider market, and it's a great example of how we can work together as partners to really improve outcomes for residents. We've done some really creative work in that space, and we have made a difference. So in conclusion, the recommendation for board to please consider today is to retrospectively approve the Q3 return, which is, as I say, Appendix A and B of the pack.
Thank you very much. Thank you, Sarah, and thank you. I know there's an awful lot involved in filling in those forms and sending them off. When do you get feedback from NHS England on your case study and the contents of the report?
Sorry. We don't tend to get quarterly feedback. It's sort of an acceptance of an acknowledgement of our submission, and we generally get the annual letter that comes through that kind of accepts our plan and confirms that we passed the assurance steps.
Okay.
Yeah, so Simon Raw, representing voluntary sector. So I'm aware there was a community effort in Newton to look at the discharge process and how the community and the voluntary groups could engage with the statutory bodies to improve the process. It could be everything from transport to get prescriptions to socialisation, all types of things. But I know they found it impossible to get proper engagement with the statutory bodies. And I know this kind of cuts across a number of areas. And there is also, I guess, the tension between you do a top-down approach or a bottom-up community-driven approach and all this kind of. And I do appreciate that the voluntary sector is not always the easiest to engage with more widely. But it does seem a little disappointing that initiative at Newton has kind of hit a roadblock. Now, I do understand the community groups there are just going to go ahead and see what they can do as a community, excluding the statutory bodies now. but I just wondered if A, you're aware of it, and B, what's the best way for the community to get engaged? I'm obviously aware of the work Sam's doing. He came and presented at the DCA, Dorset Community Action AGM, recently and shared some details. So that's good. But it does seem a little bit of a mismatch between the messages we give about the importance of this here and the reality when you're trying to do something with a bunch of volunteers at a community level. I will say, it's not my personal initiative, and I don't live in Stir Newton. It's just what I'm hearing from the people that live and work there.
Yeah, so I think I'd be really keen to understand some of the detail and sort of the links that group have already got, so we can kind of work out how it's not kind of connecting together. And we've done a lot of work recently with our voluntary kind of the out of hospital pathways through the voluntary sector. So we've got key links at sites. So it shouldn't be. I think it's a good one for us to kind of understand the details. Perhaps I could pick up with you outside, just to work that through. So there's some folks.
Yeah, I'd be delighted to share and keep contact, and then just understand what the real issue is there, and it might be that it just doesn't work the way they're proposing, which could be understandable, but there might be something we could do.
Yeah, there's something to harness from
yeah,
either.
absolutely.
Yeah.
Did you want to?
So I think, obviously, yes. So John Price, I'm the Exec Director for Adults, Health and Housing. So I think, it's fantastic community initiatives. I think you picked up on the work that we're doing around thriving communities, which is really about trying to understand what's out there, map it, with a view to how can we enable it. So I think we've got some way to go to do that, which is obviously the example that you're citing, but that is very much in our thinking. So I would expect, alongside Sam's work, that we start to really make some headway in the coming year on that.
Teresa, and then Simone.
Good afternoon, Teresa Levy, Executive Director for Children, Dorset Council. Thank you. So thank you for your report. It is always reassuring to see the impact that we're having with a particular section of our community, but you will expect me to be asking the question again around when are we going to reopen the conversations about maybe a wider ambition around young people in particular in our Better Care Fund. What I'm kind of really alive to is that what we know locally is that the admissions to hospital for our young people just into their 20s is a really disproportionate position. And what we know is that we could have big impact upon that if we were working differently to avoid hospital admissions for younger people than that. So I'm really keen just to understand when we're going to be able to, Chair, think about those kind of other elements, which I think would also really support our board.
So we started the approach looking at carers and expanding the offer around old age carers, so that there's always more that we can do. But we've certainly made a good start, I think, in broadening some of that current offer.
Okay, I don't feel that I'm cited on that, so I feel like I would want to be really thinking about whether we've been able to have that conversation with who I think our priority groups are and how we might be able to really think about how we'd wrap some of that offer around those. So if I think about my care leavers, 500 of them, they are absolutely a really key group for us around their well-being or otherwise. So really be keen to pick up a broader conversation about that, I think, in terms of the Better Care Fund.
Yeah, of course, no problem.
I just moving forward and thinking about work programs. I'm aware, obviously, that these come through retrospectively, and I'm also aware. This is my own experience. The Better Care Fund appears to be quite a sort of complex mechanism, and there's a lot in there, and a lot to unpick. And I wonder, moving forward, if it might be worthwhile for a piece of work to be done to look more widely at the Better Care Fund, what's in it, how it works, how it's put together. I know you probably all do understand it, but it's bits of it we understand. We tend to look at the parts that relate to us, and I think that would be a very useful, some sort of workshop or that sort of thing, or a group where you could really, really dig down and dig deep into that, because there are opportunities in there and opportunities to expand it out. But to really make a very valid point, Simone's going to come in a moment, and she may have a similar question on a part that I had, but I won't take up. Do you want to speak and then Paul?
Thank you, Simone. Yeah, thank you, Simone. I'm a GP in North Dorset, particularly around Sturminster Newton, and I'm also representing the Dorset GP Alliance today. And I was just wanted to pick up on, I think, the frustration around a lot of this is about, there are a lot of initiatives, community initiatives out there that can help with discharges, etc. And I know there's been some work that's been done with John Sloper in the Anticipate the Aging Well programme. And I think a lot of it is just about joining up the dots so that you've got a single point of access that can then reach out to the initiatives like you were discussing. I think it's just formalising that, and I think that's the challenge. But hopefully as we kind of develop our relationships and more work we do with place and neighbourhoods, then that will become more straightforward and excuse me, easier to sort of make a pathway, because I know it's been frustrating, but there has to be a formalised process around it, I think. Thank you.
Thank you, Paul.
Thanks, Chair. I think there's certainly, I'd say there's merit in what you're suggesting, particularly as we're coming into the next year, and a lot of conversations within the NHS at the moment to focus on two things. One is that acute flow in our hospitals, and actually it's broader than that. And what's helpful is having a conversation here. It's the way we care for patients from the moment that they have a stressor that requires increased intervention to the moment that they recover. So let's broaden it like that. But the bit that we see from an NHS perspective more than anything is we see those pressure points pop up, and they're at the front door in EDs, and they're in our beds where people need to get home. And so there's going to be a real emphasis over this next year about we have to improve the way we manage that. Yeah, absolutely. There's going to be prevention for people getting ill, but prevention for people needing to have that expensive and often not the best care that's most appropriate for them within those spaces. And then the other thing that we will be watching really closely is where we're putting our resources. So there's a lot of pressure around NHS finances at the moment. It'll play out on the national stage, but it'll play out locally here as well. And there's a lot of investment goes into the Better Care Fund. And I think for senior leaders to understand what that is doing and to allow us to have a check and challenge that it is having the maximum effect that we can have, I think there's a definite benefit in doing that. We come away understanding it more, but also having had the ability to just sense check that the resource, where that resource in the Better Care Fund is going, it's got the best chance of having the greatest impact in looking after our population outside of that hospital setting. Yeah.
Thank you for that. Yeah, so I think there's real value in it, or there will be real value in being able to do that piece of work to really check. And there is a huge focus when we go through. The word prevention comes up. I lost count.
And apologies, I didn't introduce myself. I just realised. So that's what I've got my hand up again. So I'm Paul Johnson. I'm the Chief Medical Officer at NHS.
Had I known your full title, I could have done it for you. Know your full title. Yeah.
Hi, excuse me. Got that. Your frog. I'm Sarah Howard, Deputy Director of Place for NHS Dorset, IPD. Just in terms of an action, I'm happy to pick up with Sarah in terms of how we review the Better Care Fund and think about next steps. I think we've been talking about doing this, haven't we? So I think we absolutely need to think about how we take that forward. So happy to do
very pleased to hear that. And obviously it comes to all our meetings. It's always retrospective. We all read it, but I think just opening it up like this is going to be very beneficial. Teresa's nodding. Good. And there are other areas that we may not have tapped into that could be potentially considered. If we think about the other conversations that we're having in housing and the importance of that on health and well-being, very, very important. So, there are important, interesting and innovative potential opportunities, I think. Right, okay, fine. Are there any further? Oh, sorry.
I just wanted to say I'm Margaret Guy, Vice Chair of Health Watch Dorset. We're hoping to do some diaries with patients and their carers, just to get a little bit more understanding about what it feels like from their perspective. This is at Dorset County Hospital. So a sort of they are hoping to recruit some patients at the pre-assessment stage to actually then keep a diary while they're in hospital and then take them through the discharge process. So we'll actually get more insights into how it feels like from the patient and the carer point of view as well.
I think that's excellent. It'll be very interesting to read those diaries.
Yeah, I mean, I think it's important to say that, it is a pooled fund, and we can pool, whatever we choose to. The BCF really should be our demonstration financially of transformation. So I think all of this conversation is really helpful, but there's nothing to stop us putting children's budgets in there, housing budgets in there, different budgets from across the system. So I think all of that is always potential, and we probably haven't exploited it as far as we could. So moving forward, this is a 2-year BCF, but there is an opportunity to look at the second year of that funding. And certainly in this year, the case study shows, how you can achieve, some innovation through channeling some of the funding. So I think lots of what's been mentioned are opportunities for us to look at that innovation moving forward.
And obviously also later on the agenda, we have the neighbourhood teams work, and that is clearly an area where there may be opportunities as well. So thank you very much, Sarah. If you want, you're going to stay. You were brilliant. Thank you. Thank you so much for all the work that you put into it. Now, going to move on to agenda item 8, the joint strategic needs. I'm just going to be introduced by Frank.
Thank you very much, Chair. So I'm Sam Crowe. I'm Director of Public Health for Dorset Council and also BCP Council. And I'm just going to talk to the paper fairly briefly today. I'd like to highlight Natasha Morris's work on this. Natasha couldn't be here to present today, so I said that I'll take the paper in her absence. But she's really been, I think, the key person that's led the development of our joint strategic needs assessment process from something that's much more than a collection of health facts into something much more rounded. Represents a lot of insight that's been gathered from service users, but also people working in frontline services, as well as some of the standard metrics that you would see in an assessment of what our population needs are highlighting as priorities. So just to kind of remind the board, it's a statutory duty of health and wellbeing boards to prepare and host a joint strategic needs assessment. Every year I say the same thing. I say it is joint. So public health do with the sort of engine room, if you like, so we can't do it without really good engagement and involvement of all of our partners. It is also strategic, and it's supposed to be an assessment, and I'd say those quite deliberately. So people looking for somewhere where they can find out everything that is possible to know about health in our populations will be disappointed. We never managed to capture all of that. What we're trying to do is we try to take the best of that information, we try to synthesize it, we try to summarize it and build a narrative in a way we believe helps tell that story. And the point of that is to help our organisations in our system use it as a tool and a resource to then ask good questions about what do we think our priorities are around population needs, how effectively are we using our resources to meet those needs, what are the public saying in terms of their experience of some of the responses to meeting those needs, and really to use it as a building block when we're starting to think about strategic planning. So I'm not proposing to go through the narrative summary in detail today because I'm keen that we have as much time as possible for the discussion on integrated neighbourhood teams, but that's another really, really good hook. I'd hope that this is exactly the type of work that needs to be taken into account when we're thinking about what's the purpose of these teams, where are the long-standing challenges in Dorset that we haven't always managed to be as effective at meeting as we might have done. And just some headlines from Nat and the team's work. There isn't really a huge amount of change when we look at the collection of information year on year. Dorset tends to have a very similar pattern overall. Health tends to be very good, but that experience isn't the same for everyone. This comes through very, very clearly in some of the slides that accompany the appendix in the narrative. You pick out one of the indicators that we've picked up on the children and young person space, childhood obesity. The map across Dorset looks relatively benign. Most of those smaller areas are doing better than England in terms of rates of obesity and overweight. The one area that isn't is Weymouth and Portland. That's not Weymouth and Portland's fault. It's a picture that you will see repeated all the way across England, an association of higher prevalence of obesity and overweight in areas that are more challenged and areas of deprivation. If you look later on in the life course, you'll also see that pattern being repeated when we look at the standard data on things like emergency admissions, or if you look at variations in how well conditions are managed, if you look at variations in the rates of early death and disease and disability from some of those long-term conditions, they tend to vary, and often that's in line with the social gradient for health. So one of the other key themes in the JSNA narrative every year is to try to encourage people when they're working through what might be the responses, to always have that thought in mind. Are we really reaching everyone? Are people engaging with our care offer? And if they're not engaging, do we understand why they're not engaged? Start to put some of that thinking into the response when we're designing services. And that's particularly important that we do that with people in communities, because quite often they will tell you very quickly why they're not accessing services, and we need to listen to that. So I hope partners will find it a useful document. We are very, very open to receiving criticism. So if you find that it's not working, if you find that it's not as accessible, please do let us know. The other important point about the process is that this is very much a high-level strategic summary. It isn't the same as the type of detailed needs assessment work that we would do if we were doing a major piece of service planning. So if we were recommissioning a particular service, we'd obviously do much, much more detailed work, working with colleagues and partners. But again, this should be really the companion piece of the integrated care strategy. And that's another reason why we've collected the resources, framed them against those three priorities in the integrated care strategy. So you'll see a section on prevention and early intervention. There's a section on thriving communities, which talks about a lot of those wider issues that can affect how people access, respond to services and their experience of health. Then the final section is some thoughts from information that we collect around how we might work better together. I think one issue I would pull out in there that I think is really worthwhile of the Health and Wellbeing Board paying attention to is that variation in access to private transport. So if you look at the proportion of different populations right the way across Dorset that have access to a private car, it does vary, and that presents real issues when we're thinking about delivering services differently, particularly county across Dorset. So I think that's possibly all I wanted to say today. But the overall message from me is I'd just like to thank everyone who's taken part in preparing this and the engagement workshops. I think we've come a long way since 2012 when it was first the responsibility of Health and Wellbeing Boards. But we get a lot of good feedback, particularly about the narrative summaries. People find them quite engaging and they're quite useful. And there's a whole host of links and other data that will be on the website. So the recommendation today is for the board to note the narrative and to publish this as the 2023 summary, and also to support that we publish this on the JSNA website along with all of the other resources. Happy to take questions.
Thank you very much, Sam.
Margaret Guy, Vice Chair of Health Watch Dorset. I found it a really good read. Thank you, and thank you for referencing the Health Watch Dorset report. Thank you. Can I ask about locality profiles? Obviously they used to be done, I suppose, with district council boundaries. I wondered if the reason for you're waiting to know what the neighbourhoods are going, or you then do sort of lower level needs profiles or what the plan is for those. So we were talking about it at our PPG meeting in Swanage last night, and people were very interested to see, the data at that sort of level.
It's a really good question, and I'll tell you what I know, and anything I don't know, I will get advice from the rest of the team, particularly Nat Morris, because I'm sure she's got a plan in mind. We do have locality profiles. They're accessible from the Public Health Dorset website. They're based on a whole series of national public health indicators collected when Public Health England used to use those local area profiles. What we've done is we've taken a cut of that data so that you can see in the former, I think they're the clinical commissioning group boundary areas, you can kind of look at sort of basic comparisons between some of those indicators. I think the more interesting question is going forwards, if we were a client to the forming neighbourhood teams, what would they wish to see in something that's helpful and particularly helps them frame some of the questions around what might be the challenges? How does that particular area stand out? What makes it different? That might not be quite the same as some of the publicly available national public health data that we normally throw into our profiles. So I think there's an amazing opportunity here. And also don't forget, we've got the Dorset Intelligence Service, which has got a huge range of, much richer primary care data in many instances. So I think it's a really nice question, and one that I'd be happy to take away, because I'm sure Nat's got a plan. A very, very good question.
Teresa.
Yeah, thank you. Thanks, Sam. Really helpful. And maybe it's only because I'm just coming out the back end of a 3-week CQC and Ofsted inspection that I'm feeling like there's a good opportunity for us to be continually challenging each other, but I'm going to do that. So there's a couple of things in there for me that I was thinking, if we really appreciated that data, are we feeling that we have the right response to that in our present delivery? So I would, of course, look at the young people who are having a higher level of admissions to hospital for alcohol and self-harm and challenge us all to say, are we seeing suitable commissioning intentions and delivery options to really minimise that? And it's a challenge question, a provocation really. But I guess the other one that really struck me, and I thought, wow, that would, if we appreciated that in the true sense of appreciative inquiry around data, would change everything. 65% of our community do not think they have the right level of social engagement. 65% of our community. So it's worse than other places, but even other places, of course. So if I'm wondering what we would do with our commissioning intentions, with our kind of service design, if we were really to be thinking about that. It is worse for older people, but 65% of the entirety. And I think that level of what we know about young people who are going to have good life outcomes is if they leave school with these 2 good friends. So we are beginning to think about how we support people building friendships, because it's a really important soft indicator. But I just think there's something for us as a Health and Wellbeing Board chair around what's the data going to drive in terms of our commissioning intentions? What's the data going to drive in terms of thinking about where we put our focus? And those are the 2 that really struck out for me.
Thank you, Teresa. And they're stark numbers, aren't they, as you go through them? Does anyone want to comment to Teresa's challenge?
Thanks, Teresa. I can give a partial answer to the first. We've seen a real improvement in the number of young people in treatment for drug and alcohol use through the REACH service, and that's reported through the Combating Drugs Partnership. I suspect a lot of the people who are captured and lie behind that statistic may never come forward for treatment formally. So these are probably times when people are getting intoxicated. It's not necessarily dependency or problematic, but it's problematic that they've had to end up in hospital. So it's a really, really good question to ask. I particularly like your second framing of the second question, because that's exactly the sort of strategic question which we're hoping the JSNA starts to drive. So when all services are thinking about that really challenging dimension of loneliness and social contact, what are we doing to think beyond just the basic provision of service, and are we really inviting in other people who might be able to help with some of the solutions around that? We're at a very early stage with the Thriving Communities work, but certainly that's some of the conversations that Dave Thorpe has been having with neighbourhood groups and organisations. But of course, there's always a challenge if you're aware of that group, you may well be already engaging with them. If you're not aware, there might be quite good reasons why you don't feel able or willing or ready to go and engage with that group. So I think it's a great challenge.
Thanks, Sam. It's one I'm really willing to lean into. Thank you.
Yeah, I mean, I have an advantage in some sense in living in a very rural area and understanding a lot of those that isolation issue. And I think what I see in some of my communities is there are a lot of people who would wish to start up some form of activity on a very small scale, but nonetheless an activity that will then bring people out of their homes and together. But they may fear that they need to get some kind of permission to do that. And it sort of prevents them on oh, do I need to sign something? Do I need a risk assessment or a this or a that? And I might need some money for some biscuits and tea and coffee and that these smalls. It seems small, and but I think if you're just wanting to help within your community and just bring some people together, just getting that permission or feeling you need to, when actually you want to go ahead and do it, go ahead and do it. Just empowering people a bit more to make those movements forward.
Hi, yeah, Simon Raw from the voluntary sector. I guess this question isn't really related to the voluntary sector. There was a very interesting piece by the Shadow Health Secretary, Wes Streeting, I don't know, 2 months ago. You probably remember it better than I do. And it was about the need for a mental health strategy and the particular problems facing men. And a lot of that resonates within Dorset because in rural communities, loneliness, suicide rates, drug abuse, etc., all kind of come to the fore and spring to the fore. And I just wonder if there should be, or if there is, a focus on any kind of key things, and whether that's something that we should look to think about in the future, particularly because I read the piece. I actually raised mental health strategy at the Health Wellbeing Board, either the last time or the time before, can't remember. And I just want to ensure that we're not overlooking it. And if we do put it to one side and focus on other issues, that's a conscious decision.
Yeah, thank you. I just feel there's a real alignment here between the three papers. So yes. What we've heard previously, the JSNA, and in a moment hearing about the integrated neighbourhood teams. And I think the JSNA is going to be absolutely crucial as a reference point alongside resident and community engagement to help drive what we focus on. And then I think the knock-on effect of that is, again, kind of coming back to the Better Care Fund, is thinking about how we utilise those kind of pooled budget opportunities to think about particular needs within particular neighbourhoods or localities.
You read my mind. And I agree. There is a theme here, isn't there? There is definitely a theme and a symmetry with these papers, which is really pleasing, actually. We're seeing these threads now coming through everything. Sam?
Thanks, Jake. I was just going to respond to Simon's question about mental health strategy, because I'm interested in the board's view, really. I think I've got strategy-itis, if I'm being honest, because a lot of them around. One of the things I've been thinking about is we've had a new national suicide prevention strategy. It's published in January. The next stage is we're supposed to be refreshing our local strategy. I've been thinking that public health still holds this, partly because we're short on capacity at the moment, but there's a bigger question behind it, which I think touches on some of the points that you've raised, which is about behaviours, groups in the population that do suffer from some inequality, and sometimes we overlook it. We don't talk enough about the inequality in suicide. It's very, very stark in middle age between men and women. So progress that I've made is that the new Mental Health Delivery Board will be the new home for public mental health and suicide prevention. It's early days, but we've had a commitment from that board to hold it in the system. Because I think just about public health being engaged with it We've got some large providers, we've got some large organisations. Voluntary and community sector also have a lot to say around these issues. I think if we can give a greater visibility to those issues through that forum, that's where I'd like to see part of that work taking place. But of course, that's not the only men's health issue. I think sometimes when resources come down nationally, as they have for the women's health hubs, quite easy to mobilise people to get re-engaged in that because there is some resource. I don't see any signs of that resource coming down nationally, but we should still keep some of those issues on the table.
Thank you. Yeah.
Thank you for that. Paul?
I kind of agree with Sam in that we could have a strategy for everyone and everything, and I guess it's trying to work out what is it that it's trying to achieve. And if you reflect, that there shouldn't be an automatic because we had a women's health strategy, there should be a men's. There was something that drove the need for a women's health strategy in that there were ingrained inequalities that women were experiencing in their access to healthcare, and particularly around healthcare that is focused on conditions that are either solely or predominantly experienced by women. And so I think that inequality drove it. I think there are still things that are particular to men or are more prevalent in men, and behaviours that are more prevalent in men that make access to healthcare or engagement with healthcare more challenging. And I don't think we should lose that. I think that should be part and ingrained in our planning and our understanding of our population. I think wrapping it in a strategy of its own, I think it would have to be really clear what are the problems that we're trying to solve that need a strategy, as opposed to what are the things that we're identifying in that particular part of our population that just need to be part of how we design our services and how we engage our community.
Thank you very much for that. Just one more point on this.
Just very quickly. I mean, I think it would be, it's nice to hear there's recognition. I think we need to be careful just not to dismiss it as strategitis. I appreciate that's not what you. But there are some real health inequalities here. Men die younger, they commit suicide more often, they're more lonely. And it's not about the need for strategy, it's about the need for where we focus our efforts and the action. So the social interactions for the majority of the male population may look different and feel different than the social interactions, for example, for a female population. How you reach a male population around suicide and suicide prevention may be different than how you do it for the general population. So it's not about having a strategy for the sake of it. It's about making sure that the actions we put in place recognise the different needs of the demographic, really.
And I won't bring you in, Teresa, but I'm sure there's a whole raft of information that are also on young men as well. So you don't need to respond to it. Unless you really want to.
I was going to say something else actually, but thank you, Jane, just for because Sam, you and I I'm actually a bit uncomfortable talking about suicide and mental health strategy in the same conversation as a complete kind of synthesis, because actually we know that they're very connected and very separate, and so there's just something about kind of being mindful around that. And we've talked about that before, Sam, haven't we, in terms of kind of really thinking that through. I think there are two epidemics in our society at the moment. I think we've got a violence against women and girls epidemic, and I think we've got a mental well-being challenge. And I think there is something about whether it's a strategy or a real clarity of approach, we need to be stronger, I think, in both areas as our part of our partnership. So I'd certainly support the strength of it. However we describe that, I think we do need to strengthen it. Sorry, Jane, I had to.
No, it's all right. I tell you, you're on a roll. I think we'll leave that there. I need a proposer and a seconder, but could you, Sam, ensure that Natasha is thanked for this piece of work? And thank you very much, Simon, for your very valuable it's very valuable. Thank you. And that need to be taken on board when considering future work. So thank you. Right. We are going to move on to. Oh, did I not get that? Proposer and seconder. Oh, brilliant. Thank you. So many people wanting to propose and second. Right, we're going to move on to place and integrated neighbourhood development. And this is going to be presented by Sarah Howard. It's something I'm very excited about. And I'm very pleased to have this paper. I know a lot of work. I know you've personally done a lot of work on this so far. So do you want to begin your presentation? Thank you.
Thank you. Thank you very much. So I'm certainly going to begin the presentation, but then look to colleagues around the room who have equally been involved in conversations with myself and others, and indeed contributed to the paper. I'm going to take it that you've all read the paper, so I'm going to pick out some of the key highlights. So I think, again, and sorry to mention the word strategy, but going back to our integrated care partnership strategy, we talk about working better together and thriving communities and prevention and early help. And I think the discussions we've been having collectively over the past few months around integrated neighbourhood working, integrated neighbourhood teams, and the wider place development all kind of add or contribute to those outcomes within the strategy that we've seen. So to date, the approach that we've taken has really been a kind of a pilot approach, really, with Portland, in terms of thinking about how do we really utilise the data, JSNA and other data from our DICE system and other things as well, plus listen to the local residents and community to really understand what's important for somebody's health and wellbeing. So we've had a range of really key themes from residents of Portland that hopefully, and the next stages of this work is that we need to kind of come together back with the community, which we're going to be doing in May, to really feed back those key themes and really identify what we feel we need to focus on. Now, some of those things are absolutely in the remit of health and social care. So things like access to unplanned care, for example, has come up time and time again. Things like children and young people's mental health has come up on numerous occasions. But equally, things such as green spaces and parks for walking dogs and transport are other really key themes that, again, we're hearing time and again. So a word that John and I were kind of speaking about earlier on in a meeting this morning was connectiveness. So what we really need to do is make sure that we collectively, from a health and social care perspective, focus on what's within our gift, if you like, so the health and social care elements, but that equally we make sure that we're connecting other parts of our system to support the neighbourhood development. So linking with our transport colleagues, our voluntary services colleagues, education and all that kind of thing. In terms of where we're at more broadly, we do now have a integrated neighbourhood team board that's been set up. We met for the first time last week. It's in its first meeting, so it really is in its infancy, and we need to kind of develop the terms of reference and membership and that kind of thing. It absolutely feels that the conversations are progressing at some pace now. And I was very kindly invited yesterday to Dorset Council's extended leadership team meeting, where Jen Lewis, who I think might be on the call, gave an update on place-based and locality working, and really broad conversation around what that means from a Dorset Council perspective. So it feels that Dorset Council, NHS, we're all having the same conversations now, and I think reaching the same kind of point in time. So I think the key for the discussion this afternoon is really to think about and get some direction in terms of how we take this forward. So we've done the in-depth piece of work with Portland, and that will continue. I presented to the town and parish councillors a couple of weeks ago at their conference, and for about an hour afterwards, every single town and parish councillor come up to me and said, can we go next? Can we go next? So there's something about how do we do this? How do we stage this in a way that works? Where do we want to focus our efforts next? And is there something that we can be doing across the whole patch, whilst we might be focusing on more in-depth kind of conversations in some areas? I'd like to welcome John and Simon, who might want to contribute as well.
That one? Oh, I'm not used to this technology, sorry. I think, thank you, Sarah, for your work. And I think I'm very excited that you're excited as well, Jane, because usually I'm just the excited one. But I think this is a massive opportunity. And it does go back to, as a GP, my frustration in years gone by is that we always feel that we're working in parallel, kind of across the sort of the council staff and our staff. And actually, we often find that there is duplicate in services. And so to have the opportunity to really develop a true sort of neighbourhood team, I think is such a great opportunity. I guess the wicked problem is potentially the how. There's the sort of top down or bottom up, and I would be very much let this be an organic bottom up approach. Sort of thinking about actually, yes, we need to use the data, and we've got the DICE, we've got the JSNA, we've got the 5-year forward plan and the ICP strategy. We've got lots of data that tells us things we should be focusing on. That can also then give us a little bit of a local theme as well. And yeah, let's ask our populations from that information what's important to them and how you, I suppose the wicked problem is how do you give that a structure so that we're not just, and I think this is the point we made when we had the conversation with John of the Alliance the other day, is how do we have some structure and form without being too top heavy on governance that allows organic growth? And I think that's the bit that I'm kind of like not quite clear. And I think that's maybe what we're all talking about today. But I think the will and the passion is definitely there. I think the other thing for me is that this isn't just about health, and we need to be really clear that this work is really about actually populations and health and well-being. And if that's the bit we need to get right, because I think it always comes from health, and sometimes we override what might need to happen underneath from other organisations' perspectives, public health and councils especially.
Yeah, I think it is an exciting piece of work, and it's a kind of game-changing piece of work, but it is very, very complex, and I don't think we should shy away from it. It's important that we put the resident at the centre of it, and I think in the Portland example, that's what's been done. We've used data to target, where the key problems were, but actually the co-production is the really powerful piece from the Portland piece. So I think the approach works very well. We recognise that in the DC footprint, there is quite a lot of difference. So we need to recognise that as well as we roll this out to more rural areas. But it's a really good example of partnership working as well. Voluntary community sector, fantastic. So, all the ingredients for a very exciting future.
Thank you. Yes, how are we going to do this? How is this going to happen? Every area is going to have a different need, or not. Teresa, Teresa, I'll come to you in a moment. I've got lots of things in my head about this, because I came to you with a session at Portland and listened, and then you very kindly came to a small session that we arranged in the north, and it was very different people, very different requirements, very different needs. So it's got to be flexible. I suppose the really important question is, from my perspective anyway, is it's vital to resource this properly. If we really want this to work, it's got to be well resourced, and how and who resources. How is that resourced? That's funding. Is that going to be jointly? Is it going to be separate? How would that work? That's pretty key. We may have a wonderful idea, but we have to have people to make it work. I don't think I'll speak anymore, because as I said, I've got lots of things in my head about this, and it is for me a really, really important change maker for Dorset Council, and for our residents, and for the people that work with them as well. That co-production is essential, absolutely has to be. Teresa.
Thanks, Jane. Yeah, so thank you. So I think the good news is that we're not kind of at the first base on this in many places and spaces, and that we've already got a lot of locality knowledge and understanding. And of course, the local authority, by the nature of having those place services, also a connected space already in terms of knowing quite a lot of detail what the people who we serve have as a kind of desire in their places. And of course, the local elected member role in terms of wards and as well as the towns and parishes are going to be really important. So I think there's a real governance and people who local residents elect role in this as well. I think it's really important for us just to name that early on, because I think that then allows us to kind of really think about that local democracy. But I'm also really struck by when we've been doing lots of work in the local integrated localities across children's level, which we'll talk more about in the family pathfinder work in a minute. Our people really don't care about how we organise ourselves as long as we're more integrated. I think that's the reality kind of says. There's something about they've already told us. They'd really like us just to get our pathways aligned, get us working together. And I think so co-production is right in terms of what it might look like, but I think we shouldn't think we're starting with a blank page. We've had years and years and years of listening to our residents, haven't we? And knowing what it is that tell us, which is just get yourselves together and sort it out, really. I think the other element, though, is that there are some things none of us would want locally. We accept that some specialisms need to be away from our local space. You know, I want the best heart surgeon. I don't mind travelling. You know, I don't want it to be at the end of my street. I've got that. And I think some of the things we need to have really honest conversations about is, you know, what is it that we don't have in that local space because it's right and necessary that it isn't local. So I think, as you say, Jane, lots and lots of questions.
Yes, thank you, Teresa. And I've been really conscious in various spaces and places very recently, and papers that have come forward, particularly in children's services with the work that you're doing and the family hubs, and sitting there thinking they are there. The spaces are there and the services are going to be required within them. And that all fits in together, so we don't have duplication, overlapping. We use what we're doing and strengthening it with all the specialisms that are required. I suppose my other question has been from the beginning of all these conversations: who leads this? And it's place-based. It feels it's local authority, but is it? So my question.
Thank you. I'm really glad you asked that question. I was going to ask it as well in terms of who leads, because I wanted to re-emphasise the point Simone made, that this absolutely isn't a health-driven agenda. It's about all of us working together collectively with our residents and communities. So I think in terms of who leads, I think is something we do really need to agree between us. But also just...
Where do you agree that? Do you agree that?
Programme board?
No, please. I mean, this is sometimes we talk around things. It's where is this agreement going to be made? How is that going to be mapped?
Am I the host of the difficult questions? Oh, look, I've got to be in another meeting.
No, but I mean, it's just where is that conversation going to be had?
Well, I think the conversation is being had. It's happening. Right now in places. It's happening here. It's happening yesterday in the conversation that Sarah joined in SLT. I think the key to that, as has been said, is that it needs to be resourced, and that for me doesn't feel like something that's necessarily just a bolt-on to something that somebody's already doing. It might be, but I think we really need to think carefully about that in terms of what resources there are. You'll be aware, probably more than most in this room, perhaps a couple of colleagues on the call, there's a little event taking place in May early. And so in that sense, we're sitting waiting to see what is the direction of the new administration of the council to understand whether they want to, what resources and emphasis they want to put behind it. Have I said that opaquely enough? Or clearly?
You have.
Yes. So we would be more than happy to resource, but we need to understand that sits within the new structure and focus of the new council.
Right. It doesn't prevent the conversation.
No, it doesn't. And we're having it. We are having that conversation, absolutely. And I suspect what we'll have for a new administration is, and here's an answer if this is the direction you want to travel in.
Thank you. Sam.
Thank you. I was going to come back to a couple of the questions that were in your paper, because one of them is about who's going to lead it. But you've also asked what are the key areas of focus for integrated neighbourhood teams? Example, admission audits, intermediate care, or is it picking up on those wider issues that residents almost certainly will come forward to? We've heard about a big one today, social isolation and loneliness. That's a very different response to some of the more NHS couched ambitions. And I just think we ought to be clear, there is a tension there, isn't there, between this started life recently as a recommendation from the Fuller report, as an NHS review of integrated locality working. We've also tried this a couple of times through the clinical services review, where we tried to invest in primary care to do locality working, and it didn't last very long from a resourcing perspective. So I'm not raising this to be difficult, but I think that question of, what's the purpose is fundamental, because until we've got that question right, this could go off in quite different directions. It'll have quite a different flavour, and it might be okay that develops differently depending on each of the neighbourhoods and the challenges. But there's something about how we marry up the quite different views of this from different parts of our system. That makes sense.
Paul.
I think that's a really good question. I guess I would change it in that we probably need to think separately. What's the purpose and how do we evidence it? And I think we evidence it predominantly by surrogate markers. I think everything we talk about in integrated neighbourhood teams, there isn't one measure that we can do that says, tick the box, we've done it. But there are surrogate markers that will demonstrate that we haven't got a community and services wrapping around that community as effectively as we can. And therefore, emergency admissions into hospital or unplanned admissions or people dying in a location that is not of their preference, all of these sort of things that may sound very NHS are actually surrogate markers for, are we wrapping things around effectively within that community? So I would say there is a freedom in defining the purpose that doesn't have to have a metric attached to it, as long as we understand how can we indirectly evidence that as a success. And then that allows the tension of both to be held, I think, because then we're not doing it purely for admission avoidance, but we would be concerned that we're not delivering it effectively if we see the number of emergency admissions that could be avoidable going up, for example.
So I think you're right, Paul. I think we've been counting emergency admissions and trying to reduce emergency admissions for many, many, many years, and nothing has changed. So I think actually addressing the underlying issues and social isolation, lack of care, those sorts of things, networks, are the things that actually people need. And I suppose communicating with those populations as opposed to just doing to them is the other thing that we need to think about when we're looking at this. I don't know if any of you are aware of the complete care community work that James Kingsland's done. And it's a national example whereby any primary care network was able to bid for funding, and it was to reduce health inequalities in their area. And it could be anything that was pertinent to that area. And we, in the Blackmore Vale Partnership, we got some funding. We're talking very small amounts of money, just to support the setup, but to do our carousel clinic. And actually, you just put a proposal in, and we have meetings on a regular basis. It's very light touch governance, but the organic growth. And I went to this symposium earlier this month. When you hear about all this incredible work that's going on, these are neighbourhood teams. They are teams of teams. And I think if we're too prescriptive about what teams are, actually you'll stifle transformation, you'll stifle innovation. And so I guess, again, going back to that wicked problem, how do you enable this sort of innovation, as well as have a little bit of governance and a little bit of process and a little bit of pathway? But as I say, the complete care communities, they've managed to do that nationally, and that's just a sort of footprint that you can look at.
Margaret Guy, Vice Chair, Healthwatch Dorset. There's a reference in the paper to Healthwatch Dorset being involved in the group or the board, or wasn't quite sure what it's called. And we obviously, Louise Bate, our manager, be very keen to be involved. I'm not sure whether she's had that invitation yet. but there's a reference, I just saw it, potentially it says Health Watch, I think, in here as well.
I'll definitely make sure that she's invited.
And can I just say, I'm obviously I have a Purbeck hat as well as a PPG chair in Swanage, and you came to our group, which is a bottom-up group, Action for Health and Care in Purbeck, and in a sense that group's there was a degree of frustration because we used to have a Purbeck Health and Wellbeing group, and that ceased really, but with COVID, so that we got together and got our group going again. But it's very much a bottom up, and in a sense, because there seemed to be a vacuum in terms of what's happening in terms of neighbourhoods. But it was very striking at our last meeting, although we are looking across Purbeck. This is the meeting, not the one you were at, the next one. The Swanage and Wareham are very different. And so it just comes back to this point, how low down or how do we define neighbourhoods? And I mean, obviously there are issues that we do need to discuss Purbeck wide, but there's no doubt that the people who live in Swanage are different to the people who live in Wareham, and the issues are different. So
you highlight the point very well. It's the need for flexibility.
Yes,
because every area is going to.
And we had councillors
and similarities, and yes, exactly. Teresa, I see you have your hand up.
Thank you. So I just really thanks for the nudge, Margaret, because I'd really want to recommend to you, Sarah, the DPCC as being a board member too. We know that organisation represents our Dorset parent and carers beautifully, and I think that their voices, and again, our young people don't want to. Sorry, they don't want to sit on our boards. They've given us that message really clearly, but they're very happy for their Dorset Youth Voice team around them to be a representative. So also really keen to have that kind of co-production element right in from the very beginning.
Thank you, Teresa. Good shout. Poor Leslie. She's everywhere.
Everywhere, all the time, all at once.
I know. There are some specific asks here. There are obviously place leadership, and that's an ongoing conversation, and I feel that we're making inroads very much with that, and we'll reach a point where that's decided upon. Key focus areas for integrated neighbourhood teams. I think that's a very wide question, and possibly a bit too wide for today, but that's clearly the whole point of what neighbourhood teams are about. Additional neighbourhoods to focus on in the coming year. I'm obviously going to put a shout out for the rural patches because you haven't been to them yet. I'm sure Simone will be very happy to participate in all of that. But that will be up to decision makers. But yes, I would put a shout out. That doesn't necessarily have to be in the north rural, but just saying. And how soon do you think that you'll be able to identify your next areas? And I guess that's also going to be a question about resource again, which will be part of those wider conversations.
So, thank you. That was a really helpful summary. And I think things are really moving at pace now. I mean, John and I have probably seen each other 4 or 5 times in the last couple of weeks, specifically talking about integrated neighbourhood teams. So even since writing this paper, things are moving on at pace. So I think with that group, and once we expand and make sure we've got the correct membership, then I think we can get to the point where we start having the discussion to quickly move on to what we can do across the whole from the bottom-up perspective, but also what we might need to support a bit more hands-on from a programme team kind of perspective. So thank you. Been a great discussion.
Well, thank you. I know you've been hard at it for a long time, and for putting this together and running this way it's really helpful. I've been watching from a distance and a little bit closer as well as it's moved on, and it definitely is moving at relatively swift pace, really, considering all the organisations involved in doing that. And I feel that we will get to a point. It'll start to move forward more quickly. If there aren't any more questions, do I need I need another proposer and seconder, please. Thank you, Matt. Proposer, seconder, anyone?
It can't be easy to remember.
Oh,
Yeah, I can't did our previous chairman. But yes, he's right. George is absolutely right. I'm not thinking a member of the board. I shouldn't have spoken earlier, should I?
who knew?
Well, George. Well done, George.
Get back to him.
No, share it
Right,
the
well, we have a proposal. Thank you, and thank you very much. Looking forward to more of this and more information coming forward and being involved further in this. Now going to you.
My apologies, Chair. I've got a ministerial briefing.
Yes, and thank you very much for your valuable contribution, even though you're not going to be here. Perhaps change that.
Interlocal.
Okay. Agenda item number 10, which is Families First, Pathfinder and Safeguarding Children's Partnership Annual Report. And that's being introduced by Teresa Levy, who is on. Oh, no. There we go. Thank you.
Thank you, Chair. Yeah, Teresa Levy, Executive Director for Children's Services. So thank you. I'll assume everybody's read the report, and I'm just going to flip through a few slides quickly. The annual report is for both matters, and it's quite right that they will come together in this way in the future too. So as many of you know, following the National Policy Review, Dorset have been chosen to be one of the first 3 pathfinders. The second wave has just been announced, but I'm not able to tell you who those next 6 local authorities are at the moment. That remains embargoed, but we know that the rollout of this programme, having significant changes across the way in which the whole of the partnership deliver family help, child protection and safeguarding partners' roles, is a rollout programme that will continue throughout this year. It has significant changes for us, but not so much as the rest of the country, frankly, because the way in which we're already working in this very integrated way across our children's services at the present time. What it does change up is the way in which we deliver family help. So we already have a very extensive, over £4 million investment in family help services here as a county. Family help will be extended into what would previously been known as child in need work, so what would have been undertaken by social workers previously, in order to maintain security of relationship. What the kind of national research is based on is that actually people build strong relationships with their family worker, with their family help worker, and it's important to be able to stay with them. We'd already had a piece of work undertaken ourselves here in Dorset by Oxford Brookes University, looking at how well the locality model was developing and delivering. And that piece of work is available, published now. Told us a number of very important things, showed some real impacts actually in terms of how that locality family help working was going, changing people's lives, supporting them alongside the families, safeguarding families together work, which I'll say more about in a moment. But it also told us really importantly what we felt we already knew, which is there was a very significant prevalence of domestic violence and abuse in our families' experiences, and that where families were working with family workers and appeared in old money to escalate through into a higher level of need and therefore often transfer to a social worker. Actually, it wasn't that things had got worse in the family. It was simply that the workers had built the relationship with the family, that they were able to talk more about what was happening. That's not rocket science for many of us, but it's an important distinction which says that it's not necessarily in the majority of cases that risk and need escalates, but more that we as a professional network and as the partnership working with these families get to know about it. And therefore maintaining those relationships is really key. So we'll be doing more of that. We'll be doing making sure that more and more of our families stay with the people they're with. To ensure that's safe and sound, we're investing a significant amount of the additional money that came from the Department of Education in having social work oversight of that practice at an assistant team manager level. And we're also investing in much more in multi-agency child protection teams who can do really deep work quickly with families where there are child protection concerns, other than those families who are already working beneath that sort of level. That does mean us changing up our child protection conferences, so there's much more work around families being at the heart of the decision making at that point. That work's just beginning to roll out now. It's delayed for a few weeks because of the inspection, but we're now back on track. Family networks, so we've always worked on the basis that we know that children really rarely live with mum, dad and 1.6 other children. They absolutely live in complex family scenarios, and they also live in communities where people in the community are often incredibly important to them. So the family network approach really requires us to think about family in that much wider context, and at the very beginning of any intervention for the whole local area partnership, to be thinking who is your family, who are your go-to people, how do we engage with them? And that engagement may be in a range of ways, and it's including a financial support package for people to be able to support families to stay together. This is for information really rather than in detail, but we are enhancing our locality model. Significant number of new roles. We've been pushing on in the last few weeks and months to deliver this. This is changing all the time. This should be a kind of almost a tally board going on, because it's actually going up all the time. We've now been able to recruit to over 60 new appointments. Really fantastic level of interest in colleagues coming from across the country. So more than 2/3 of those are externals, people coming to a range of posts that we're investing in heavily. And you can see there, just as a kind of a quick capture, the youth support workers that we're putting into every locality to work with our schools to support children back to school, to support them staying in school effectively and happily when they're there. We've increased that number by 14 posts to have a much richer offer across our localities. We know that if our children are in school, they're much safer, but we also know we need to do more to support them to stay in school. So a range of posts, a range of opportunities, and a range of success in recruiting those colleagues who will make sure that getting that kind of communication out to all of our partners to be really clear about who's in your locality delivering what will be one of the parts of our induction of this new programme, which we're saying doesn't have a go live date, but will happen around the end of April, May. What else to tell you that's significant? Because there's an awful lot, so I'm not going to kind of go through it. It's in the report, really. The safeguarding partnership. So the triumvirate of health, local authority and police now becomes whatever they call for something. Is it a quartet? Well, they have to be for now. We'll try not be a string quartet because I can't play. But fundamentally, there'll be 4 key players at that table, and the 4th one is described as education. Now, at the moment, we're still waiting for the Department of Education to describe just how that role might be configured in what is, as you all understand, a really complex framework now of schools. So we know we have academies still local authority maintained, and we have free schools, and we have independent schools, and we have a raft of hundreds and hundreds of early years providers and a raft of further education providers within our county. There isn't a natural representative of those colleagues other than our Director of Education, Amanda Davis, who at the present time will be taking up that role and therefore taking that lead as we go forward, thinking about how that might change as we go forward. But a real opportunity to make sure that there is a go-to person who will be able to talk about safeguarding in our schools community. Lots of things going through. So updated timetable there. So we have had a little bit of a delay, as I say, because of the unexpected inspection, but fundamentally we are continuing to still be pretty much on schedule for sort of spring start, and that will continue through as we make some of those changes. Increasingly important, that just doesn't really note that what's been incredibly important about the Pathfinder work so far has been the seconded colleagues from health and police who have worked incredibly effectively with the local authority staff. So we're just talking, weren't we, about how do we do this? Well, I think the way in which your staff, my staff, have done this so far in terms of the Pathfinder has been extraordinary. And we've seen some real extensive work across how and who are going to work in those family hubs, doing what and delivering what. And that's been a really straightforward piece. Once we've put people together in that room and said, OK, practitioners and senior leaders, work that through. They've absolutely worked that through at pace, and they've got a real clear capture upon what the opportunities are. We haven't got fixated on governance or sovereignty of, do we have to have one organisation leading these teams? We understand matrix leadership really well in children's services because that's how we operate, and that matrix leadership across the multi-agency teams is our approach. So we're not doing T's and C's, we're not going to be doing consultation of who's your boss, but a really clear matrix leadership role works really well, and that's how those teams will be configured into the localities in the future. swift change. I can pause there for any questions about that aspect, Chair, if that's helpful before I move on to the Safeguarding Partnership report.
Thank you very much, Teresa. Yes, Sam has a question.
Thanks, Teresa. It's really good to see the progress around the new model. Just something I picked up from papers, this point about CAMS integration at some point, and I just wondered if you could say a little bit more about that, because obviously access to child and adolescent mental health services has been quite a challenge in Dorset for many years. Do we hope that that will improve through incorporating that in the front door?
Yeah, thanks, Sam. Absolutely. I can't think how I've got to say it, except we spoke about it so much with the inspector, I think, in the last few weeks. An incredible piece of work led by the entire partnership group, Rachel Small and Elaine Hurl and lots of local authority leaders coming together to say just what would a Thrive model really look like. What we know around the Thrive model is the problem was that it weren't the same kind of touch points. There were lots of extra and different touch points. And the outcome of that work to date has been acknowledging that we want services where young people are already. So certainly the mental health services in schools is the right thing, and we'll carry on with that approach. But what we know is that we took an approach of saying, like, what's working really well at the moment? We know that the CAMS front door isn't. Our own local authority front door is a very steady access point. Turnover of inquiries into referrals is within 1 to 2 days. So the access to a service point has that kind of achievement at the present time. And that's because it's based upon a conversation-based model. And so a lot of the contacts, people phoning up, have that opportunity to really explore, is this the right place or is there somewhere else, and how do we move through some of that? We know that many people have told us that that's what we would like as a first point of contact for CAMS, is to be able to be somewhere where they can have that conversation first to determine, is it the right route for me? Do I need to go on that waiting list? Or actually, is there something else that I can access? So having that integrated at our front door into the future is clearly something that we feel our families would benefit from. And work within health colleagues across the CAMS system have spent time in our front door watching, observing, modelling what that might look like, and really feel that's a great opportunity. So it's not about kind of sucking anything into a new place, but it is about giving a new space to be able to avoid waiting lists if that's the right thing to do, because actually a bit of simple help and advice and guidance might be the right thing, and or being able to have one single point of contact for anybody who's not able to get that access. The problem with mental health teams in schools, as you will appreciate, they don't work terribly well for children who aren't in school. And when we think about those elements, it's a real challenge. So having that kind of integrated front door is really important. Yeah, thanks, Sam, for the reminder.
Are there any other questions for Teresa at this point? Okay, Teresa, we've got more slides.
Thank you. Just hopefully this is still sharing for you. Yes, I think so. Okay, so very briefly, you'll all know we presently have a Pan-Dorset Safeguarding Children's Partnership. The annual report needs to come to our cabinet, as it has done, and to this board. It's produced by the partnership and signed off by James Vaughan, who's presently our independent chair. One of the rather odd situations of the national policy change is a requirement to move away from having independent chairs for our safeguarding partnership. And because we're a pathfinder, we need to move away from that more quickly. So that's very much a task for us this year. And it also means that we may well move much more to a place-based approach to how we do our safeguarding partnership work. But again, those conversations are all happening with those appropriate leads across police and health at the present time. I think the important element to pick up from this board is that there has been some really clear policies and priorities that have been met across the last year. They are in coordination with BCP, but obviously we have slightly different intonation at times in terms of what we focus on. So, for example, our issue around county lines and serious youth violence is significant but different to BCP's, and so we work to have the same priority but work at it in a very different approach, really. We have shared activities around any child protection, overview, practice reviews, as you know, and those have been continuing on both sides of the partnership all year. One of the things that I suppose has been a real theme for us around the death of a young person on the railways in Weymouth this last year, but also some other deaths that didn't feature in a CSPR, Children's Services Children's Safeguarding Practice Review, but did feature in our hearts and minds around young people in our community who died following some ordinary behaviour around alcohol and around being engaged in ordinary teenage and young persons' behaviours, but also then died by misadventure of accidents in dangerous places like quarries and rivers and railway lines. So we've been really focused on that this year and thinking about how we make sure that our children and young people are safe in their communities too. Lots of training delivered to lots of practitioners at a very good value. In terms of how we deliver that. We understand that's really important for all of our practitioners, so we look to deliver that up-to-date contemporary training to practitioners across the system. Our priorities going forward, very much violence experienced by children and young people. We know that our young people have continued to tell us that they don't feel safe enough in our places around sexual violence. They don't feel safe enough on our beaches. They don't feel safe enough when they're out and about at night. And the evidence clearly from our police data is that they're absolutely not. So it's been important for us to keep that focus. Children's mental health and emotional wellbeing, as we've said, we appreciate that our young people tell us that over and over. Fabulous youth parliament campaigners in the last week. 10 different young people stood for our youth parliament, 10 different campaigns, all of them heartfelt, meaningful, thoughtful areas for them to be campaigning about, but many of them being about children's mental health and emotional well-being, and some about sexual violence in our streets. So our young people are telling us in all sorts of different ways and places. But in these times of real difficulty in families' well-being, we also have neglect as a final priority. We have significant challenges for families living in deep poverty, but in the midst of that, we also need to be keeping a very clear partnership eye on the levels of neglect experienced in our communities too. So that's it from me, Jane. I shall stop sharing and
thank you very much, Teresa. And questions or comments for Teresa? No, well, I have one, Teresa. And I know the enormous work that you and your great team have carried out in this space, and it was a huge compliment to you and them for being part of this in the first place. And so congratulations for that, and also the speed in which that you have taken this on and moved this forward. Very pleasing to see your successful recruitment pacing as well. And I suppose my concern really is around funding, as it is for all things. And I know that there is funding available, obviously, for this. But moving forward, that's only for a period of time.
Yeah.
And I know you can't predict and you don't know, and nobody does. But obviously, it is a and that this fantastic work, would we don't know what would happen, and I know there's, as I said, there's no guarantees, but wanting that commitment from the whole of the council really to continue to support this would what I think members would all be looking for, particularly. I just wanted your thoughts on that. As I said, I know you can't predict, but you have conversations at quite high level, so you may have some indication.
You do, Jane, and thank you. And it has been a real challenge from the outset. I'd say we have constantly been on a promise that this will result in a different settlement for children's services across the country. And I guess it was important to us as we went through this process. We came back to the Department of Education saying their initial envelope wasn't big enough and we needed to have more funding, and they met that, which was important. And then we also clarified with them, are we appointing these colleagues on permanent contracts? And they were very clear that we were perfectly sound and safe to do so, on the basis that any funding that had been allocated to get us this far would be met with a new funding arrangement. However,
very
different players. Yeah.
No, but that is nonetheless encouraging to hear that, because that is commitment, and this this is important work for our young people and our families, of which you have taken and run with it. So, are there any comments, questions? No. Okay. Well, thank you very much, Teresa, and thank you for the team who've put all the work into that. Brilliant. Right. Okay. Moving on then to the work programme, which I spoke about earlier briefly, just on one piece of work that I would very much like to see moving forward on the Better Care Fund, and opening that up and widening that out and digging deep into that. George, are there any other? Oh, yes, I do. I have another issue that I bring up around housing and having a housing representative permanently on the board in Andrew Lee. There he is, appearing on the screen. Who I think, we are hearing, and housing is coming up in all places and meetings and organisations, as a recognition that it is clearly key and fundamental to the health and well-being of our residents, and therefore having Andrew sitting here permanently on this board contributing is really vital. But I understand it has to be made a change to terms of reference. And so and so I need to seek agreement from those that they are happy for that change. I don't know, and George will have to advise whether or not it actually has to go to full council.
Yes, it's possible that the monitoring officer will advise that it has to go to full council for a change to be made in terms of reference. But if the board makes a clear indication that they want that change to be made, then we'll look at options for ways for that to happen.
So we're happy, right? I see that. Andrew, do you want to introduce yourself?
Yeah, I think most people know me, I think, but thank you, Jane. Andrew Billany, but I suppose I've got a question as well, is whether it's for the role or whether it's for me personally. I'm assuming it's for the role. So, because my role is Corporate Director of Housing and Community Safety, actually, which has got an element of relevance to this. So I make a suggestion that it could well be for the role, because it covers both of those angles, housing and community safety. So my role covers areas like domestic abuse, prevent agenda. So there might be areas where I've got the officer position to speak on those subjects as well. So maybe that's something to take forward. Just to introduce, so that's describing my role. So I'd be happy to be part of this board, but also maybe to tease out some specific items so we can get into the detail of what we mean when we talk about housing as one of the building blocks of health and well-being. So I'm more than happy to work that up as we go along.
Very good. Thank you very much, Andrew. And full agreement we have around the table.
Good.
Thank you. The other point we're going to make, George, was around writing to NHS England, who are also permanent members of this board, but they don't attend. So just for a letter to go from me, just to ask them if they would like to consider sending someone as a representative to the board. I mean, I think it's gaining traction here, and lots of interesting, good, serious pieces of work coming along. And I mean, I don't know what their role would be, but they're on the board, so if they want to send someone, please do. Politely, obviously. Are there any other pieces of work that Sam?
Just going to mention we did have a conversation which you reminded me of this when we mentioned NHS England. They've obviously written to you as Health and Wellbeing Board Chair for review about the extent to which the Integrated Care Board has supported delivery against the Health and Wellbeing Strategy. And I've been having a conversation with NHS Dorset to say it'd be good if we could evidence that rather than just have one or two people's views. So there are a couple of people in the ICB trying to gather some evidence that the Health and Wellbeing Board could consider. One of the possibilities was that we actually have a conversation about that in the board at some point. We might need to set that up post-election rather than doing it today. It's just really to, I guess, kind of test people. It seems better than just getting one or two people's opinions. We can actually bring
a whole piece of work,
information to the board.
Yeah. No, I'd be happy with that. Anything else? I mean, we don't have to. It can always come through via George. John.
Just on the place and integrated neighbourhoods piece, I think clearly the Health and Wellbeing Board is an important governance for that work. So I think perhaps on the forward plan we should have an item coming forward because I think it's helpful to keep this moving and everyone engaged and informed.
Yes, yes, absolutely. Sam.
Would you like the rest of my list? So these are only suggestions. And some of these have come from the public health team. They're reminders of work that the board's been engaged with previously. Perhaps lost touch with a little bit. So one is the physical activity strategy, movement for movement. So that's very much a distributed strategy that Active Dorset have encouraged organisations to make their own contributions to that strategy. We could do a piece which reflects and captures some of the experience of what different organisations have done. That's one suggestion. We're doing a big piece through the Integrated Care Partnership at the moment on smoking, which gathers together lots of multi-agency work. So there's the tobacco control work in hospitals, the new offer that's just gone out around encouraging people to switch from smoking to vaping. That's part of a national government initiative called Swap to Stop. We're also getting significant new grant funding in for smoking cessation. So at some point in the year, Health and Wellbeing Board might want a view of how that's going, and there could be an ask of partners to support some of those offers.
Did you not do one on smoking, or was it in another place?
It was in another place.
Oh, okay. Sorry.
You would have heard the setup in the Integrated Care Partnership, but this would be a focused item for the Health and Wellbeing Board. We've talked about neighbourhood teams, that's good. Strategy development. There's something about post-election coming back and refreshing the Health and Wellbeing Board strategy to tie in with any new corporate plan for Dorset Council and to pick up some of the elements in the ICP strategy. And then I was going to mention suicide prevention. So if we make progress through the Mental Health Delivery Board, to have a conversation with the Health and Wellbeing Board about what we think our local strategy should be focusing. That I think picks up the opportunity to have that conversation about going broader than just focusing on suicide. What else should we be thinking about? If we're thinking about prevention of self-harm and perhaps framing it positively around well-being.
Okay, thank you. That's pretty, long list to consider, and you might want to think about that. Great. John, is there, sorry to spring on you, is there anything specifically in adults that you can think about that? Think about that. Yeah. Simone, sorry, again, not to John, is there anything particularly in your area that you think would be a possibility to look at? You don't have to respond now.
For the neighbourhood.
Well, generally, just for the programme moving forward for the board. If you think of new contact, that would be excellent. Thank you. And yes, of course, didn't forget you.
I attended a healthy ageing workshop in Wareham. I wasn't sure whether that was something that would be relevant to this board as well. That's obviously another piece of work that's going on.
That might be something to tie in perhaps with something in adults.
Yeah.
Generally.
It was being led by the council. So
yes, yeah. So to tie in as a bigger piece perhaps. Anyone who has any topics or areas that they think would be worthwhile looking or bringing to report, then please just contact George.
It'd be lovely to have an update on the Thriving Communities work in due course.
Yes.
That's going to be a way down the line.
Yeah, I think that's sort of
Yeah.
Okay. Yeah. Okay, well, if there isn't anything else, then can I thank you all very much for your contributions today, and I've done it within 2 hours. Look at that. Masterful. Thank you very much. I'm not sure when the next meeting is, but I'm sure George will let everybody know. There's no exempt business, so we're done. Thank you.
Excellent.